So hello guys, in this video we are going to discuss the Neet PG 2019, the recall questions, memory based obviously, based on the inputs given by our students, the questions and the options. Let's see them. Okay. So number one we have, there is a child with recent history of fever, lesions with sclerotic rim in the upper end of tibia, identify the condition shown. See, what you see on the image is a tibia where in the metaphyseal area of the bone you have got a lytic lesion with some sclerosis somewhere around the lytic area, right? What all are the conditions in which you can see the cystic lesions of the bone, right? So cystic lesions in the metaphyseal area of the bone, they can be multiple. For example, you can have a unicameral bone cyst, you can have an aneurysmal bone cyst, you may have this kind of lesion which is a part of osteomyelitis. So these are some common lytic lesions that you can see easily. If you talk of some higher in this diagnosis, the malignant ones, then you can have certain malignant disorders. But our condition says the child with recent history of fever, lesion with sclerosis in the upper end of tibia, identify the condition shown. It is a recent onset of fever, so less likely to be a case of something malignant. Okay. So lesion with sclerotic margin, there is no other constitutional symptom which is mentioned. So we just consider it to be a part of something which has got started showing its manifestation very recently, right? So number one option we have is a Braudys abscess. What is a Braudys abscess? See, sorry, Braudys abscess is a kind of subacute osteomyelitis which basically has got off and on symptoms and signs. Now why some osteomyelitis will have some off and on symptoms and signs? It is just because of the reason that either the patient's immunity is very good, or there is a decreased virulence of the organism, or you have started the antibiotics before the onset of the symptoms. These are the three common reasons why there would be a subacute osteomyelitis. That is what you call a Braudys abscess, right? Second is osteoid osteoma. Why this cannot be osteoid osteoma, or why this can be? See, osteoid osteoma basically, it is a tumor which occurs in an eccentric location, number one. Second, it involves one of the cortical area, number two. Number three, osteoid osteoma is located at diaphyseal area. This is not a diaphyseal area, neither it is on the cortex, so less likely to be a case of osteoid osteoma, right? But osteoid osteoma, as I said, some malignant conditions may be related. Osteoid osteoma may have some sclerosis around the lytic lesion. Number three, hemangiomas. This is not intracortical hemangiomas. See, first of all, when intrahemangiomas, they are uncommonly to be seen in the long bones. Number one, hemangiomas have a predilection for your spine, skull, pelvis, and in the long bones, if any they are seen, they can involve any of the locations. But then they have got a particular typical type of presentation like corduroy, jail bar, or maybe the polka dot on the cross sections. This hemangioma unlikely site the tibia, the spine, skull, pelvis being the commonest sites. The chondromyxoid fibromas, that should have enough this fibrotic change inside the lesion. Why there should be a sclerosis all around, right? Now this is what you call a Braudys abscess, which is a kind of subacute osteomyelitis with off and on symptoms and signs, right? This is how it presents. And in Braudys abscess, usually the diagnosis is basically made by a culture from surrounding area of the this lesion, right? In majority, you will not be able to find the abscess. The cavity would be empty. When you put a needle, you all know that the best way to identify a infection, the osteomyelitis into the bone, is put a needle, aspirate it. You will find abscess, send it for culture and sensitivity to know the best antibiotic and the organism which is responsible for this infection, right? So that is what you call a Braudys abscess, the off and on symptoms and signs. This is a subacute osteomyelitis, and if you find somehow lot of sclerosis around this particular cavity, see this cavity, if you see lot of sclerosis all around this one, this cavity, here in this portion you are going to see some sclerosis. But if you see lot of sclerosis all around this cavity, then that's what you call the sclerosing osteomyelitis of Gare, right? Number two, we have the most common joint involved in septic arthritis. See, it is basically the knee joint. In some old papers, it has been said that it is a hip which is commonly involved, right? But knee, isolated knee basically has the most common tendency to acquire the infection from the surrounding soft tissues also. So knee is the most common joint which is related to septic arthritis. The septic arthritis of the hip joint, which occurs in a child of less than 1 year of age, is what you call a Tom Smith arthritis. Okay. Number three, which we have is, which statement is correct about the pathology shown in the image, right? Now in the image, what do you observe? There is a lytic lesion. See, all of you can recognize that this is a radius and that's your ulna, and you can see this lesion which is all around the radial area, lytic lesion on the distal margin, epiphyseal area. Now there has been a question in your AIMS exam, May session, in your All India exam 19. So you can understand how simple the papers are, right? How the simply topics are asked to you, the simple questions are being asked to you. Now this is a lesion which is located at epiphyseal area. Now we should know that this epiphyseal lesion may have what all differential diagnosis. So if you have read your topic of tumors very keenly, and you have been in your class, I simply say that to learn bone tumors, it's very easy. You just need to learn three important things. Number one, location of the tumors. Number two, nature of the tumors. And number three, some special feature of the tumors. There is no need to mug up the tumors like a theory. We are not preparing for a theory exam. We are going for PGMEs, right? So read smartly, catch out the points which are important for us, and that's all what needed. Now for this differential diagnosis at the lesion at epiphyseal area, right? What all are the probable differential diagnosis? Diagnosis can be, number one, either giant cell tumor, the osteoclastoma, or the chondroblastoma. So we have got two. Now giant cell tumor, the age group is 20 to 40, which means skeletally mature. Chondroblastoma usually 10 to 25, skeletally immature, right? Here in this particular image, you don't see any of the epiphyseal line. There is no epiphyseal line. That means it is a skeletally mature case. Second important point, the giant cell tumor, they have a tendency to occur around the eccentric area, right? So one of the side of the radius, the lateral side is involved. Gradually it will expand. It is expansile lesion, so it will expand to the other side also, right? Now this giant cell tumor, which statement is incorrect about the pathology shown in the image? So my diagnosis for this particular X-ray would be a giant cell tumor. Tumor arises from epiphysis to the metaphyseal region. Very true. It occurs at the epiphyseal region, but in skeletally immature children that may occur at a metaphyseal region also, in rare cases. This is an uncommon thing, but yes, it may happen. Tumor has distinct margin. You all can see that. Eccentric lesion, yes, it's an eccentric lesion to start with. Later on it expands and involves a whole bone, and chemotherapy is the treatment of choice. See, chemotherapy is usually reserved for the cases where you have a systemic involvement of the particular lesion. Until unless you have got a systemic lesion, why would you like to go for a chemotherapy? Better the treatment options for giant cell tumor we have. Number one, curettage and bone grafting, LO or autograft, curettage with bone cementing, or if needed, if it is going into malignant transformation, the rate of malignant transformation for which is less than 5 to 10%, then you can go for further surgeries. Like if it occurs at a distal radial area, you can just excise the distal radius and replace it with fibula. We have got two options here, either arthrodesis or arthroplasty, meaning by change it with the fibula or just do the arthrodesis, right? So resection and replacement with fibula is one option for distal radius. If the lesion is involving the knee region, then what to do? In the knee area again, if it is unicondylar, then you can go for the curettage and the bone grafting or bone cementing as you prefer. Cementing and grafting has got disadvantages in both of them, advantage in both of them, which I have told you in the AIMS questions also. This knee area, if it is unicondylar, the options we have is either the curettage with the grafting, or number two, there is another question that you had in some other exam also about this lytic lesion only. In knee area, you can have the hemicondylar osteoarticular allograft also. The grafting process, single articular area is being replaced or curettage done and grafting is been put. If needed, you can do the endoprosthesis also for the joint area. If the lesion occurs in some other bones like the lower end of ulna, which are not making a part of your wrist joint, you can just simply do the resections. And if it occurs, the giant cell tumor occurs in some inoperable site, if it occurs in some area of the spine, if it occurs in some area of the pelvis, you can use the radiations also, right? So treatment options we have for any of the case of giant cell tumor. Number one, curettage only. Number two, curettage with bone grafting. Number three, resection and replacement with fibula. Number four, replacement with the implants, endoprosthesis in the knee-like area. Number five, radiation if it occurs in an inoperable site, right? Chemotherapy doesn't have a role to play because giant cell tumor is a benign aggressive lesion. The percentage of the proportion of going into aggressiveness is only 5 to 10%, less than that, right? So chemotherapy doesn't have a role to play in the cases of giant cell tumors. Number two we have, or the next one we have is a foot drop is caused by injury to which nerve? So it is all know, basically it is the common peroneal nerve, right, which is leading to the foot drop, which basically gets injured around the proximal part of fibula, right? Pott's Puffy tumor. See, Pott's spine, Pott's fracture, Pott's Puffy tumor. Pott's spine is what you call a tuberculosis of the spine. Pott's fracture is what you call a bimalleolar fracture, medial malleolus and the lateral malleolus. Pott's Puffy tumor is none of them. It is basically a subperiosteal abscess which is under the frontal bone. That's what you call a Pott's Puffy tumor. Okay, what should be the most likely diagnosis of this 65-year-old lady presenting with backache and following radiograph of the spine is as shown in the image? In this particular image, what do you see? See, there was a discrepancy in this question. What actually was asked? Some said listhesis, some said something else. Let me show you both the pictures. I'll show you both of them. See, in this particular X-ray, if you observe this particular vertebra, see this one? You can see, if you observe the margin here, this particular vertebra has gone ahead of the lower vertebra. This is what you call listhesis, spondylolisthesis. That is slipping of one vertebra over the another vertebra, right? So what should be the most likely diagnosis of this 65-year-old lady presenting with backache and this? If this was your picture in the exam, then this is what you call a spondylolisthesis. Some said it was not listhesis, it was a codfish. What is a codfish? See this? See this vertebra, this is one vertebra, and look at the upper margin of the vertebra, this is like this cup, lower margin of the vertebra like this. At every level you have this appearance in the intervertebral area. This is what you call codfish spine appearance. If this was the question, the codfish spine appearance is basically related to your osteoporosis, right? So first image you have seen the spondylolisthesis, and this is what you call codfish spine appearance. The most common diagnosis, the most common reason basically for this codfish is osteoporosis, okay? Painful arc syndrome is felt during, what is painful arc syndrome? See, painful arc syndrome has been a very old MCQ some 10-12 years back in the AIIMS exam, and recently it has been asked again. What is a painful arc syndrome? See, when I abduct my arm, there is no pain till here. Now the pain starts, it is painful, it is painful, it is painful, and now the pain disappears. That means pain during this mid-range is what you call the painful arc syndrome. So pain during mid-range of abduction is painful arc syndrome, right? So it is just mid-abduction. The option A you have, it is a mid-abduction. What are the reasons for a painful arc syndrome? Most common, the most culprit tendon for this condition is what? Supraspinatus. Is supraspinatus tendon. See, supraspinatus can have tendinitis, it may have calcification, or it may have partial tear. Do remember, it is a partial tear. If the question says it's a complete tear, that means when I have this 0 to 15 degrees of abduction, it is done by my supraspinatus only. If there is a complete tear of the supraspinatus, anyhow, it is not possible to initiate the abduction. There is no abduction, there is no question of painful arc. So, it is a partial tear of the supraspinatus which can lead to painful arc syndrome, right? So, pain during mid-range of abduction, most common culprit supraspinatus, tendinitis, calcification or partial tear. Then you have the next one, which of the following attitude will be seen in a patient with posterior dislocation of the hip? See, attitude of the patients, when you talk of the shoulder or of the hip, it remains same for the dislocation purpose, right? If you talk of the shoulder or the hip area, see, if this is a glenoid and head of the humerus or the acetabulum or the head of the femur, if somebody wants to have a anterior dislocation, how the head should move? The head should go like this. That means it should go into external rotation, right? Range of external rotation is always more with the abducted limb. There is a flexion, abduction and external rotation. The option number 3 you have, the flexion, abduction and external rotation is the attitude that you'll have when somebody has a anterior dislocation. Reverse way, the posterior dislocation, the head has to go back on the posterior side. It can only go back when there is an internal rotation, right? Internal rotation will be with the adduction deformity of the hip. Okay, so in posterior dislocation you will have the adduction and the internal rotation. In anterior dislocation you are going to have abduction and external rotation. Okay, next one we have, which part of the scaphoid is most susceptible to AVN, right? Which part of the scaphoid fracture is most susceptible to AVN? See, language of the question is very dicey. Okay, so which part of the scaphoid fracture is most susceptible to AVN? Meaning by the fracture at which site will lead to avascular necrosis. See, scaphoid, if you see in my wrist, it can be divided into 3 sections, the proximal part, middle part and the lower part. The fractures are common at the middle part, middle 1/3. And the blood supply is retrograde way, the blood vessel go like this, comes back into the body of the scaphoid like that. Okay, so it is what you call a retrograde blood supply. If the waist is the commonest site to undergo fracture, the proximal part will lose the blood supply, right? So it is a middle third which is the commonest site of fracture leading to the avascular necrosis of the proximal part, right? Proximal part of the scaphoid. Next we have is true about decurvent tenosynovitis of the finger. Finger is held in mild extension deformity at the involved finger, affect the APL, APB. See, decurvent tenosynovitis, what it is? It is an inflammation of these two tendons which are visible at the base of your thumb. The abductor pollicis longus and the extensor pollicis brevis. The most commonly involved is always the index finger, no, that's also wrong. treatment is surgery. No, in majority cases it can be treated conservatively. If somebody has got the inflammation of the thumb, why the thumb will be held in abduction like this? If you are trying to keep it in extension, about decurvent tenosynovitis, they want to know the true statement. So only one statement is true here, that is APL and EPB. If I try to overextend it, if I try to flex it both the ways, I am going to have the pain. So why the fingers will be held in mild extension? Fingers don't have a role to play here. Decurvents, it has inflammation at the base of the thumb, right? So nothing to do with the fingers, number one. So option A is absolutely wrong. It affects the APL, EPB is correct. Most commonly affected is index finger. That's also wrong because that has no role in relation to the fingers. Treatment is surgery. Majority decurvents, they are treated conservatively by the use of splint, by physiotherapies, by medications. If not getting improvement, we give intralesional steroids, right? These are being for the decurvent tenosynovitis. So it is a condition related to the thumb and not to the fingers. Okay, so the most common presentation I wanted to tell you, see in decurvent tenosynovitis, what happens? There is a condition, other condition that is known as Dupuytren's contracture, basically which affects the finger. The first option written to you, this question was about decurvent tenosynovitis. I'll tell you something about the Dupuytren's contracture. Dupuytren's are the one which affects the fingers and there is progressive contracture of the fingers. Most commonly affected in Dupuytren's would be the ring finger and then there is a progressive contracture. The most common presentation of Dupuytren's would be some nodular swelling into the palm and the sole. When you try to palpate the palm area or the sole area, you will be able to feel multiple nodules. The nodules that you feel in the palm region are what you call the Garrod spats, right? And in the sole area, these are known as the Lederhose disease. So Garrod spats and the Lederhose disease, these are a part of your Dupuytren's. So in Dupuytren's, you have affection of the fingers commonly. In decurvents, it is related to the thumb. Okay, so these are all the questions basically. Okay, so these are all the questions basically from your Neet exam 2019. These are memory based recalls. Some options may be up and down, but topics remain same. Focus on the topics which are repeat in your last 4 years, 5 years of exam, right? And these are important. Orthopedics is a short subject. Don't expect anything hi-fi from it. Stick to the basics and that is what all needed. Do remember, we are preparing for PG, we are not doing PG, right? So stick to the basics and that is what all needed in orthopedics from you, right? Basic conceptual reading and revision is the key, the way to get out of the Neet exam, the very easy way to qualify the Neet exam, right? So thank you very much. Just revise these topics and if anything needed, feel free to contact us anytime. Social media, WhatsApp group, everything we do have, so feel free to contact us anytime. Thank you very much.